Hi, thank you. And I'm going to speak mainly from a CDRN perspective who sees that we've got a little over 16 months left to get this project cooking to where people
Perfect.
look at
And
it.
it's going to be a cultural shock because you're going to have to take the easygoing Midwestern approach and accelerate it.
Okay, so I'm going to run down my list, maybe bounce it around a little bit. So CEO appeal to me would be patient-centered is an altruistic goal. And I mean, that's why I think many people are in healthcare and as opposed to other industries. So I would hope that it fundamentally, that patient-centeredness could rise to directly appeal to the innate desires of the CEO as a human being. The other item would be low cost. So far, we are not asking our CEOs for any money. So that's good. Now it may be different at other CDRNs, but if we can take a very low cost approach initially on this, where we're not asking for funds for the research, that's a plus. Because I think that's important because I don't know yet that we've formulated a really good value proposition that other people have outlined of how we're going to get there. So I think the altruistic combined with low cost initially would be a good initial approach. I want to skip down to strategy with the board. I am not sure. I'm not knowledgeable about really interacting with boards, but I think, again, going with the patient-centered approach and how most, whether you're a for-profit or a nonprofit institution, fundamentally, typically you don't go wrong with having a patient-centered approach to your business in healthcare. The third point would be I would like to touch on the CEO steps to enlist patients and families as active allies. For our network, so we've got 10 institutions that are largely aligned with NIH clinical translational science boards. And those, as part of those awards, you have to have a community engagement section in your award, which oftentimes serves a slightly different focus than the health system. So it's traditionally focused on vulnerable populations, which is good. And also, I'll touch on that a little later with PCORI's objectives. But we see kind of if we can figure out how the CEOs can give time, and then the CTSA community engagement sections can also give time and come together, that'd be a really good team to figure out how we increase patient engagement with patients. Because you'd be bringing in kind of a community perspective, a research perspective together with the health system perspective. And hopefully intelligent people would come up with a great solution. So that's the third point. I then want to skip down to measure of progress by 2020. We were talking last night at dinner, and there are goals of PCORI, which I will get wrong, but you've got metrics you're supposed to hit to demonstrate by 2017, is that right? And they include things like reduce practice variation, improve the life of everybody, and reduce disparities and variability in disparate populations. So I think those measurements, it's the word there is measure progress. So we need to measure progress in things like the actual reduction in variability. I would think we would want to measure reduction in resource consumption, and we want to measure increases in quality of life, longevity, and also patient satisfaction. Because I think for the health system, that patient satisfaction, things like Press-Ganey are key metrics you can look at that probably everybody's looking at to understand their impact upon patient-centeredness. Then going on to the fifth item then is, so then when you want to measure things, how do you measure things? And you measure things typically starting with data. So I would see for infrastructure element, the key first infrastructure element is getting the data together. And so on that front, coming up with low-cost ways or ways that can integrate data is going to be the key component for a lot of this network, and I think that's where a lot of the initial focus of PCORNet is. So just making the CEOs aware of what steps are happening in terms of data integration and data structures is going to be important. That leads on to me to the next policy signal. So to me, I'll blend this with the final element, which is obstacles, and that is I think the biggest signal in many ways would be giving data back or lowering the barriers. And I will say barriers, and sometimes barriers are like a hard stop barrier, and sometimes barriers are just the inertia of getting at the data. And the more barriers you have to get at the data on your patients, that frustrates both the people in the C-suite as well as the IT teams who are practically trying to get things done. So I'll give you just a very simple little example of data. We get the Social Security Death Index data at KU. I don't know if is everybody familiar with that. It tells you, and this is, perish the thought, this is identified data with Social Security numbers and names so we can actually match it up. And you could use that for observational research, which would be good. We're using this right now largely on the research side of the house, not on the hospital side. But one simple benefit that I didn't realize is we contact people to see if they're interested in clinical trials. The dumbest thing, which is valuable, is when you use this software like I2B2 to define a cohort of people you want to contact is maybe you don't want to contact the people whose Social Security thinks has died. And there's recently been some changes to make it to where you got a couple little extra hoops to hop through to get access to that data from Social Security, which is a barrier that some people would say, oh, screw it, I'm not going to do this anymore. But I think in IT, and in systems, you face a lot of these little barriers. So a strong signal from the federal side would be really look at a lot of the key data people are going to need to understand their populations. That could be data in CMS. Longer term, it could be data that ONC shepherds throughout health exchange, but really with an eye towards, how can that data be repurposed back to the health systems and the researchers to understand quality, which gets to kind of the final point, and cut me off when I got to run, but there's really obstacles on, it's not an obstacle, but I think it's three, this is just coming off the top of my head, three things we balance. Healthcare is fundamentally a reactionary business. If you look at most of the time you spend, and this is going back to when I was first out of college and was in hospital administration in the Air Force, is everything, and then it was the military, so it's regulation. You got to do this, you got to do that, you got to do that. Here comes the Joint Commission inspecting your facility. So so much of your time is probably devoted to being in a reactionary environment. If you're Audrius and you're a CIO, every time somebody brings in a system into your hospital that you don't fully have the expertise to understand, I used to think of it when I was managing commercial systems. It's like a terrorist is bringing a bomb into your organization, and when you turn it on, you're trying to minimize the damage. So therefore, you don't want to take upgrades very often because you definitely want a couple other people to go first. So the last thing you want to be is the first guy to take the brand new release of that product because you're worried it's going to explode in your hospital. In contrast, when you're doing QI like Peter Margolis, you really understand the systems you're working with and you're in close contact with folks, so you're iterating rapidly, ideally, but you're taking off small little chunks of risk. And then the third component we run into in healthcare is occasionally you have like a blockbuster impact like endoscopic surgery, which just totally changes the game. So I think when we're looking at these obstacles, it's often cultural of when are we introducing a process improvement that needs that kind of tempo. When are we dealing with, and that's mainly in a system that's reactionarily focused. And then when is it something where we really got a blockbuster? So I don't know if the MRSA thing's a blockbuster or not. But it's hard, I think, for organizations to figure out how to balance those three things in the organization. And as we look to do PCORNet over the next 16 months, we want to think about when can we interact with people at a data layer, which is low impact on the organization, and they can kind of watch it evolve, versus when do we want to get more intertwined with the healthcare delivery process, and is that best done in a reactionary model to say PCORI says you got to do it, or is it something you introduce in a QI kind of model, or is it something where you really think you've got a blockbuster? So those are kind of my takes on the points.
Thank you very much, Russ.